Thank you. Thank you very much for that kind introduction. My talk today will be on neuroimaging in ophthalmology. And at the outset, I'd like to thank the college for giving me this opportunity to speak to you. My talk will be mainly so 15 minutes is probably not enough for me to speak to you on the intricacies of neuroimaging. So I'll be focusing mainly on MR imaging. And mainly on MR imaging around the orbit. I'm a clinician, so it'll be more of a clinical talk, and I'd like people in the audience to interact as well. You must be falling asleep by now, so there'll be a lot of questions, and I'd like you all to interact with me, so that we learn together. All right. So over-reliance on imaging in the absence of clinical localization can lead to diagnostic confusion, right? And a key step to optimizing the role of imaging in, especially in neuro-ophthalmology, is determining what tests is best to use in a given clinical scenario. And there is no substitute to a carefully obtained history and examination. And once you have a clinical anatomic localization, then it is then that you decide on the best imaging modality and also the region of interest. Okay, so I said it's going to be interactive. So this is a case history. Anyone can answer, right? So it's Mrs. S.J., a 32-year-old woman who presents to the neurology clinic. I'm a neurologist, so neurology clinic, with a complaint of acute vision loss in her right eye over the past 2 days. She also reports experiencing pain in the right eye, especially with eye movements. Visual acuity in the right eye is 20/200, left eye 20/20. Pupils, there's a RAPD on the right, and the left is normal. Fundoscopy is normal. So which part of the anatomy is involved? Yes, very simple question. It will take longer than 15 minutes. I'm not going to move if you don't answer. Yes? Which part of the anatomy is involved? Yes? The optic nerve. What do you think it is? Come again? Optic neuritis. Very simple question, right? Okay. So what would you order? You'd order an as a clinician, we would order an orbital MRI protocol, right? And what does an MRI protocol for the orbit encompass? It's a T1 weighted sequence with contrast, gadolinium contrast, T2 weighted as well as flare sequences to detect inflammatory changes, a stir sequence which suppresses fat, because you know that the orbit is full of fat, and that can affect identifying pathologies, especially the inflammatory pathologies. So what we do is we basically suppress the signals that are coming from fat. So that's called fat suppression, and that's basically T2 weighted contrast enhanced and a contrast enhanced T1 weighted sequence with fat saturation, which is essential to detect inflammation. So these are the sequences of MRIs that were done on this patient. You can see that there's some enhancement of the optic nerve, and then of course you see these lesions. What do you think these are? Yes? Simple? Yeah? What do you think these are? Optic neuritis? Neurologists? Yes? Is optic neuritis due to multiple sclerosis? You can see the periventricular and juxtacortical lesions, which are very typical for multiple sclerosis. Now, how do we decide whether so when we are dealing with demyelinating disorders, it's a spectrum, isn't it? Starting from multiple sclerosis, now we've got NMOSD, that is neuromyelitis optica spectrum disorder, as well as MOG antibody related disease. Has everyone heard of these disorders? Yes? Yes, right. So based on MR imaging, there are certain things that we look for to suggest that this may be MS, this may be NMOSD, this may be MOG antibody-related disease. So typically, if it is unilateral, we are most likely thinking of multiple sclerosis. It often involves the anterior part of the retroorbital segment, right? And it is less than half that is involved. So that's very important, okay? So it's a short segment that is involved. It is generally retrobulbous, so therefore you will not see anything on fundoscopy. And that is exactly what you see also on imaging as well, right? And there is less extensive gadolinium enhancement. So the optic neuritis that you get with multiple sclerosis is not as severe as the other entities. And also you look for other imaging features to support your diagnosis, which would be like demyelinating plaques, which involve typically the periventricular juxtacortical regions of the brain, as well as infratentorial and spinal, and can also involve the spinal cord. And they can also involve the corpus callosum, which are typically called Dawson's fingers. Next. This is a 35-year-old female presents with sudden onset of bilateral visual loss. Patient reports that she's initially experienced central scotoma in her right eye a month ago, which was treated with oral prednisolone and was diagnosed for optic neuritis. And 3 weeks following the treatment, she develops acute binocular blindness accompanied by painful eye movements. Visual acuity on the right is 20/200 and left eye only finger counting, and fundoscopy is normal. This is the MR. You can see the arrows, which are easier now. Okay, so what do you think this particular disorder is? Yes? What do you see on MR's imaging and what? So it's bilateral, isn't it? Bilateral involvement. Which part of the optic nerve is mainly involved? Do you see on MR imaging? Which part? Come again? Posterior part, exactly, yes. And you can also see, it's not only the posterior part, also the chiasm is also involved, yes. So this is typical of, so we've finished MS, yes? Which one would it be? NMOSD, right, yes. So these are very typical of NMOSD. Right, where generally it's bilateral involvement of the optic nerves. It's often either sequential or simultaneous involvement of both optic nerves. It's a long segment that is involved. So that is more than half of the optic nerve will be involved. And it's generally the posterior segment, including the chiasm. And there is avid contrast enhancement on gadolinium, which is very typical of NMOSD. And also you need the rest of the MRI to support your diagnosis. There might be lesions in the area prostrema, which is part of the brainstem, and also a longitudinal extensive myelitis also might be there. So you might have 3 or more vertebral segments being involved. Why the area prostrema and the periaqueductal region? That is because that's the region where there are more aquaporin 4 receptors. They are receptor dense, and therefore the antibodies go and basically attached to these particular areas. So this is what is typical for an NMOSD, where we look at the myelitis. And now you can see on the first image, there's also involvement of the brainstem or the area prostrema of the brainstem. So these are typical images. Right, another one. 32-year-old woman presents to the emergency department, acute onset of bilateral visual loss. She reported waking up with blurry vision, which progressively worsened over the next 24 hours. There are no associated symptoms such as headache, eye pain, or trauma. Clinical examination, visual acuity, counting fingers in both eyes. Fundoscopy shows bilateral optic disc edema. Neurological examination, there's nothing. Okay, and these, you see, you've got bilateral disc swelling, and also there's involvement of both optic nerves. There's extensive involvement of the optic nerve. So what do you think this particular disorder is? Yes? Yeah, so which part of the anatomy is involved? Yeah? Anterior part, because there is papillitis, yes. But then there is also, on imaging, there's more extensive involvement, isn't it? Right? It looks like it's most of the optic nerve is involved, right? And it's bilateral, yes. So what do you think this is? Yes, what's left? MOG. So again, it's bilateral rather than unilateral. It's generally the anterior part of, now compared to NMOSD, the NMOSD basically affects the posterior aspect of the optic nerve, including the chiasm. Whereas MOG antibody related diseases or demyelinating disease affects the anterior portion. So if you have papillitis, which is either sequential or bilateral, the most likely dealing with MOG rather than MS, right? And that is also supported through imaging. So it's often bilateral, again log segment, more than half of the optic nerve is involved. And what is very specific is that there is perineural enhancement, because the antibodies affect the myelin sheath. So you see that on MR coronal view, where the sheath enhances. Of course, the rest of the brain you'll have very non-specific lesions, but if the thalamus is involved, you're more likely again dealing with a MOGAD or MOG-associated demyelination. So this is the perineural enhancement that you see on MR imaging. Then of course there is OCT that's been used now more and more for identifying various phenotypic dimensions of demyelinating disorders. We use this. We found that the RNFL, there's significant RNFL thinning, as well as that is the retinal nerve fiber layer thinning, as well as the ganglion cell layer thinning. But this is compared to NMOSD. This level of thinning at 6 months is far less compared to NMOSD, which is much greater, and that is why the prognosis for NMOSD related optic neuritis is not that good. Yeah, so as I said, there's more severe retinal nerve fiber layer involvement, and also there's relative sparing of the temporal field in the peripapillary RNFL layer in MS compared to that of NMOSD, which is more extensive, involving both the inferior and the nasal quadrants. Right. The other aspect is that in MOGADs, right, especially during the acute phase, there is actually an increase in the RNFL values, right? And that is because there is significant papillitis and edema of the anterior portion of the disc. So that is what is picked up on the OCT. And that is now being used now to differentiate between MS and MOGAD. And you can see that there is significant asymmetry between the two eyes in the RNFL layer in MOGAD compared to that of MS. Okay? So during the acute phase, OCT can be useful as well in differentiating MS between MS and MOGADs. Right. Just to confuse the picture a little bit more, and talk with, this is a 24-year-old man who presents to the ophthalmology clinic, again sudden painless loss of vision in the right eye over the past 2 weeks. Reports that the vision in his left eye began to deteriorate 3 months ago. So again, bilateral involvement. Visual acuity counting fingers at 1 meter in the right eye, hand movements on the left. There's some RAPD on the right. Fundoscopy shows bilateral optic disc pallor. I'll go through this very quickly. There's enhancement, mild enhancement, and there's increased hyperintensity, or there's a hyperintensity involving the chiasm and the posterior part of the optic nerve, right? What would this kind of picture, what would be your diagnosis? The sequential loss of vision, the optic nerves, last case, so I'll stop after that. Lot more, but yeah. Yes. What does this give an idea? What part of the imaging suggests? Chiasm is involved, posterior part of the optic nerve is involved. Okay. What does the imaging suggest? Come again? NMOSD. Yes? Is it NMOSD? Optic nerve is involved, posterior part, chiasm is involved. Imaging suggests NMOSD, right. Does the history suggest NMOSD? No. Okay. Absolutely right. So these are actual cases, right? This patient came to me. Given methylprednisolone, I think 3 times, despite methylprednisolone and all sorts of immunosuppressants, patient's vision continue to deteriorate. Why? Because the MRI was suggestive of NMOSD. So you must be, again, it's the disconnect. You need to have your clinical evaluation connected to your imaging. Otherwise, things don't work. So this was actually genetically proven Leber's optic neuropathy, hereditary optic neuropathy. The mutation came back as positive. This is one of the first 2 cases, I think, reported in Sri Lanka. Because the imaging was very similar to NMOSD, right? But the history was not. So you need to have that clinical connect for you to use imaging. So a lot more cases, we don't have time for that, but so I just conclude here. So advances in neuroimaging have changed the way neuro-ophthalmology disorders are diagnosed. The expanding role of neuroimaging, however, does not diminish the role of clinical anatomical localization. And on the contrary, these imaging techniques should be considered an extension of the process that begins with a focused history and thorough physical examination. So thank you very much for your kind attention.